Yes, my name is Ashoka Benedict Gomes, and today I go give you some information about the guidelines for treatment in diabetic patients. Some background information. Type 1 diabetes is due to an autoimmune destruction of beta cells resulting in total insulin deficiency. Uh, while type 2 diabetes is due to continuous loss of the beta cells function, leading to a deficiency of insulin. Other types of diabetes are temporary, like gestation diabetes, which occurs during the second or third trimester of pregnancy. To identify a diabetic patient, 4 tests are used. Um, if a patient has a fasting plasma glucose uh, of greater than or equal to 126 milligrams per deciliter after 8 hours of no eating, they could be considered a diabetic. 2 hours after an oral 75-gram anhydrous glucose challenge, plasma glucose level of greater than 200 milligrams per deciliter would consider a patient to be a diabetic patient. Basically, they would give 75 grams of anhydrous glucose, and after 2 hours, check the plasma glucose level if it's greater than 200. This is called the oral glucose challenge test, and it's used to diagnose a diabetic patient. If an A1C is greater than 6.5, using the standardized lab test, it will push a patient into pre-diabetes or a diabetic patient. If a patient has classic symptoms of hyperglycemia with a random plasma glucose level of greater than 200 milligrams per deciliter, testing frequency. For overweight or obese factors with risk factors of family history of diabetes, African race, descent of African American, Latino, Native American, Asian, Pacific Islander, history of CVD, hypertension, high LDLs and triglyceride levels, polycystic ovarian syndrome, and no physical activity make a patient at risk for getting diabetes. Or patients with A1C of greater than 5.7, they should be checked every year. All these patients should be checked for diabetes. For those with past history of gestational diabetes, they should be tested every 3 years to rule out that they're not diabetic. And everyone else, testing for diabetes should start at 45 years and repeat every 3 years. On the left hand side is A1C goals based on the guidelines. They suggest recommended A1C of 7 with twice a year testing for the A1C. Depending on the comorbid condition and the person's age, A1C levels can be less stringent or more stringent. If it's newly diagnosed diabetes, they would go into the most stringent A1C or a target of 7, depending on their risk for hypoglycemia. If a person can tolerate it without hypoglycemia, a A1C goal of 6.5 can be set. In case of older people, they want less stringent A1C, as we'll see later. Above 65, it can go 7.5 as a goal to 8 to 8.5 as a goal of A1C. Some things that can help to lower the A1C include diet control and looking to keep lower postprandial glucose levels less than 180 milligrams per deciliter. So the patient should test the postprandial glucose levels and try to keep it below 180 milligrams per deciliter using medications or insulin. Hypoglycemia is considered to be after less than 54 milligrams per deciliter, and treatment can be with 15 to 20 grams of glucose. Hypoglycemia is something which you don't want to get into, but at the same time, we want to control uh, plasma glucose levels less than 180 to get a good A1C. It has been shown that if you keep the plasma glucose levels less than 180, it benefits the lowering of A1C as well as diet both. Patients with pre-diabetes should set goals to lose 7% of body weight within 6 months using intensive lifestyle programs and diet similar to the diabetes prevention program. They should also increase physical activity for at least 150 minutes per week. These 2 points, losing 7% of body weight and increasing physical activity, are the main points of the diabetes prevention program. And to achieve 7% weight loss, the diet should be lower in fat and consists of food that lower diabetes risk, like nuts, berries, yogurt, coffee, tea, whole grains, wheat bread, oats, corn, pasta, fresh veggies, greens, vegetables, carrots, spinach, lettuce, chicken, fish, seafood, eggs, tofu, low-fat dairy products, generally food in low in fat. Monosaccharide, if they have monosaccharide fats, they're okay. Complex fats are more difficult to digest. Beans, nuts, and soybean. Yearly screening should be done for those at risk for diabetes. The goal is to get a 7% weight loss, either by diet, and this is within 6 months. For obese patients or overweight patients, control of diet is also considered, as well as increased physical activity and behavioral therapy. And they should be try to go a little slower with 5% weight loss in 3 months. They can use weight loss medications like Orastat, which is available over the counter. The initial treatment is based on the guidelines, the A1C. And the guidelines say to start monotherapy if it's less than 9%, the red line. Lifestyle plus metformin would be the treatment. And they would check A1C again after 3 months. If it is okay, then monitor every 3 to 6 months, A1C every 3 to 6 months, and continue the therapy. If not, it would go to dual therapy. You would also go straight to dual therapy if A1C is greater than 9%. When you go to dual therapy, you want to add an agent depending on the ASCVD risk, atherosclerotic cardiovascular disease risk, 10-year disease risk. So you would add lifestyle, metformin, and an agent if it has ASCVD risk, an agent that would help with reduce a known FDA approved and clinical studies show that it has beneficial properties to reduce the ASCVD risk. This would be Victoza, liraglutide, and emphazozine Jardins. These two have clinical studies have shown to reduce ASCVD risk. two choices. Yeah, Invokana also has shown to reduce risk. That's canafluosin. That one though has a risk of amputation. So Jardiance and GLP-1 agonist Victoza are good choices. This is for dual therapy, lifestyle, metformin, and if ASCVD, that care should be taken with metformin. It's the initial choice, yes, but it can cause acid metabolic problems. So if the kidney function is less than 30, would not be able to use. Plus long-term therapy can cause needs vitamin B12 supplementation due to the loss. So then they would monitor the A1C every 3 months and add another drug if not at target. Each of the drugs lower their A1C differently, but approximately by 0.7 to 1%. So each time you add an additional agent, it should drop the A1C by approximately 0.7 to 1%. One thing every time when you assess this at 3 months, when you assess the patient's A1C goal and whether it's not reached or not reached, you have to consider whether the patient is taking the medication regularly, is adherent to the medication, to assess medication taking behavior. So with dual therapy, you would look to see if a patient has ASAVD6, and that would be added accordingly. GLP-1 agonist, Victoza, or SLGT2 inhibitors, only Jardiance so far, Invokana with amputation risk. Again, at 3 months, we would check the A1C and then assess also the adherence or the medication taking behavior. If not at the A1C target, 7% for most people, you would go to triple therapy, lifestyle, metformin, and 2 additional agents. The choice of agent now would be based on the hypoglycemic risk of the patient and other factors, what are the comorbidities, etc. You would also directly start. No, you don't. Okay. So then you would test at 3 months the A1C again and assess the adherence or medication taking behavior. And if it's still not at goal, you would go with an injectable medications. GLP-1 agonists also are injectable. You could also go straight to injectable therapy if the A1C is greater than 10%, or blood glucose is greater than 300 milligrams per deciliter, or they have symptomatic hypoglycemic symptoms. You would go to the green line, straight to combination therapy in that case. These are the different classes that are available, and like I said, the SGLT2 inhibitors have good CV benefits. Would be Jardiance, empagliflozin, or Invokana, gliflozin, but it does have an amputation risk here. And for GLP-1 agonists, liraglutide or Victoza. When selecting an agent, the efficiency of the agent is to be looked at. Hypoglycemic risk, weight changes. GLP-1s have the best benefit because they have a loss of weight as well as CV benefits, and the efficiency is high. So relatively a good choice for most of the indications, GLP-1 agonists. though they are injectable. There is one new GLP-1 agonist still in clinical trials, which could be an oral one. SLGT inhibitors work in the kidney, and that sodium glucose transport inhibitors. They work on the kidneys, so help. They've found to have good CV benefits actually, though there's a risk of infection. And also, the care should be taken with patients with renal impairment. And so for Jardiance is contraindicated if the EGF is less than 30. Similar to metformin. Thiazolodones, they're not used so much, but pioglitazone and Actos and Rosiabandia. Sulfonylureans have high efficiency, but a risk of hypoglycemia. And that's a point that's to be remembered. That's glyburide and glipizide. And then you got insulins, which are the best, of course. Okay. So if the patient had to be put on insulin, you would start with metformin plus another basal insulin or long-acting insulin, basal insulin. You would start with 10 units per day, or if it is depending on the hyperglycemic state, you could start with 0.1 to 0.2 units per kg per day. And you would adjust 10 to 15% or 2 to 4 units once or twice weekly to achieve the fasting blood glucose target. For hypoglycemia, address the cause of the hypoglycemia or decrease the dose by 4 units or 10 to 20. If not at A1C, after 3 months of therapy, consider combination. Add a GLP-1 receptor agonist, especially if they have weight problems or ASCVD, or they can add a rapid acting insulin before the largest meal, 4 units or 0.1 units per kg or 10% of basal dose. Or a pre-mixed insulin twice a day. If it's still not controlled, you can add a second rapid-acting insulin before meals, basal bolus. And if you've gone with the premix, you can change premix to 3 times a day instead of 2 times a day. And just to point out again, GLP-1s have CV benefits. Example is Victoza. SLGT inhibitors work on the kidney, and CV benefit is seen with Jardiance and Imacana, but Jardiance is better. Longer acting basal insulins have a lower hypoglycemic risk and should be preferred. And a little bit conversions, Lantus and Basicler go is 1:1 conversion. For patients with comorbidities like hypertension, The EDA guidelines recommend less than 140 mm per Hg, but the hypertension guidelines for diabetic patients suggest the blood pressure goal. The new hypertension guidelines suggest a blood pressure goal of 130/80. So maybe it's because of the timings of the two guidelines coming out. The new hypertension guidelines came out end of last year, and the diabetic guidelines came out at the beginning of this year, but they're very close, so maybe we want to go with the hypertension guidelines specified in the new hypertension guidelines that would be 130/80, because it has been seen patients with higher CV risks should be considered for more stringent blood pressure control. So that would be diabetic patients also who are considered at more risk of CV problems. So the diabetic ADA, American Diabetic Association, still has the old hypertension guidelines of 140/90, but the new hypertension guidelines for people with risk factors or for CV events suggest to go with a more stringent, less than 130/80 blood pressure control. Either way, diabetic patients with hypertension should be on an ACE inhibitor or ARB due to the benefit to the kidney. Also, some considerations in the diet. Low protein diet will help prevent an acute kidney injury or proteinuria, or if the patient is dialysis or CKD. ACE inhibitor would definitely be a good choice for a diabetic patient in controlling the hypertension as a first choice. So that's what they say with the American ADA, American Diabetes Association. ACE inhibitor always in all different situations. Second would be calcium channel blocker, CCB, or diuretic. Diuretic is very effective in controlling decreasing blood pressure. For the lipid management, for all ages, patients with diabetes and atherosclerotic cardiovascular disease present already, they would use a high intensity statin, which would be atorvastatin 40 to 80 milligrams, or rovastatin 20 to 40 milligrams. If a patient is greater than 40 years with no ASCVD risk, or with no ASCVD but with diabetes, then you use a moderate intensity statin. And of note, combination products like with Vascepa omega fish oils helps lower the CV risk more, especially if the patient has high triglyceride levels. In fact, a recent study showed that adding Vascepa omega fish oils helps lower the risk for CV events by almost 40% versus about 30% approximately, not exact numbers, versus the statins. So adding the fish oil, especially if patients have high triglycerides, has shown to specifically for Vascepa, they just came out with a new study that reduces the CV risk significantly versus a statin. Some points come with The complications that can happen with poorly controlled blood sugar levels in diabetic patients include diabetic retinopathy, peripheral neuropathy, foot ulcers, amputations, and they should be screened every year. For older patients over 65 years old, the goals of A1C can be 7.5, and if there's coexisting conditions like cognitive impairment, then you can go for less stringent, even less stringent, 8 to 8.5. Don't forget to click on the link to complete the evaluation for the course. Thank you.